Great.
All right, everyone. Let's see. Let's take one last head count. All right, I think we're going to go ahead and get started in the interest of time. It's a little afternoon. I'm Tina Slee, and I'm the co-chair of the PHAB Executive Committee. So today I'm standing in for Farla Kaufman, who's in Death Valley at the moment and on her phone. So I will be with you this afternoon operating the slides and the polling for some of our voting. So if you have any questions, raise your hand or speak up or use the chat. I'll try to monitor all of those things. I think there was one introduction we wanted to make. It was Siobhan Kathari. Siobhan, welcome. I understand you're the new director of Sacramento County Department of Health Services, so we're delighted to have you.
Yeah, thank you so much. No, I'm really happy to be here as well. I walked into having a great team, so I'm learning a lot from them as I go and looking forward to getting an opportunity to get to know what PHAB does and see how I can be supportive. So
do you want to tell us a little bit about where you come from?
Sure, absolutely. I'd be happy to. So I am a social worker by training. I've been a social worker for 25 years in various settings, various services, nonprofit sector, where I oversaw domestic violence, sexual assault, alcohol and drug recovery treatment, an offender treatment day center, as well as a CASA program, court-appointed special advocates. I also was the Health and Human Services Director for Mariposa County for 6 years, where I oversaw behavioral health, public health, and social services. And then more recently, for the last year, I was at the California Department of Social Services as their Chief Deputy Director, overseeing a number of programs. So I was living in Sacramento when this opportunity opened up, and was very excited to get back to local level work where I feel like the substance is and where we can see the impact that we're making pretty immediately. So just want to I am very thankful to all advisory board members who will donate your time to make sure that we're doing the best we can for our community. So thank you to you all for your work on these efforts.
Well, you sound like you're going to be a great fit for this role. So welcome. We hope to see more of you in the future.
Thanks.
I don't think I have any other introductions to make. So I guess we'll move on to the multiple sets of meeting minutes that we need to approve. There are 3 of them. And I'm hoping our board members have had a chance to review them. And we will take a vote on the meeting from the April PHAB meeting, the April 21st special meeting, and this was on the letter we were composing for the Board of Supervisors, and then on the May 5th meeting. So we'll take them one by one. We'll start with the minutes from April 7th.
Move approval. This is Steve Heath.
Perfect. Can I get a second motion on approval?
I second the motion, Farla Kaufman.
All in favor, say aye, please. And you can put it in the chat.
And I'm on the phone, so I will say hi,
Okay.
say aye verbally.
Okay. Anyone abstaining? Let's see, I feel like I'm missing someone. Annie, did you vote? Did Annie drop off? Okay. Then we will move on to the meeting minutes for the special PHAB meeting on the Board of Supervisors letter. This was on April 21st. May I have a motion to approve?
Motion to approve. Libby.
And a second, please. I second. All in favor, say aye. Or type it in the chat, please.
This is Farla. Aye.
Thank you. Okay. Okay. All right, so that one is settled, and now we have the meeting minutes from the May 5 PHAB meeting. May I have a motion to approve?
I motion to approve. It's Farla.
Okay,
I'll second Steve Heath.
thank you, Steve. All in favor, type aye.
This is Farla. Aye.
Thank you. Okay, I think that one is good too. All right, I think we're set. All right, so the other thing I wanted to draw your attention to was this appointment request for Jake Bradley Rowe to the HIV Health Services Planning Council. So that is another item I believe we need to vote on. Did anyone want to have any discussion about this nomination? Okay.
This
So,
person looks like a perfect fit for the council. So it's very good nomination in my opinion.
very good. All right. So then may I have a motion to approve?
I'll motion to approve.
Okay. And a second?
Again.
And the second was whom?
Oh, sorry, Clarissa.
Oh, thank you, Larissa. All right, all in favor, type in aye in the chat.
This is Farla. Aye.
Mhm. Okay. And it looks like we have approved the appointment of Jake Bradley Rowe, so that's great news. All right, so now I believe we are ready to get on to the main event. And we are going to have a presentation today from Andrew Mendonça. He's a health program manager with Sacramento County Behavioral Health Services, Substance Use Prevention and Treatment. This looks like a really interesting presentation, and at this stage I will hand things over to him. Andrew, would you like me to run your slides for you?
No, it's fine. If you just give me control, I can do it from my end.
Okay, then I'm going to stop sharing.
Okay. Host disabled participant screen sharing.
Okay,
You're setting on your part.
yeah, Gabrielle, can you help with that?
Yeah, I'll go ahead and make him a co-host.
Thank you.
Okay, you should have ability to share now.
Can everyone see my screen okay? Presentation there?
Yes.
All right, perfect.
Good.
So good afternoon, everybody. First off, I wanted just to thank PHAB for the opportunity to present today. Today is just really a kind of a high-level overview of the substance use prevention and treatment division here within the Department of Behavioral Health Services. I wanted to present to you everything that we do, and just really give you some highlights of things we're working on and some great collaborations that we have in place and some of the work that we're doing. I also want to take a moment to introduce Lori Miller, who's the division manager over the Substance Use Prevention and Treatment Unit. She's also joining us today, and hopefully if you stump me with a question, she'll come to my rescue and save me. But we are both, I think I speak for Lori, we're both really excited to be presenting this to you today. So a little bit about us. Our mission is to provide a culturally competent system of care that promotes holistic recovery, optimum health, and resiliency. Our vision is we envision a community where persons from diverse backgrounds across the life continuum have opportunity to experience optimum wellness. So we really take that to heart. It's on a lot of our computers. It's up in our department. And we really use those as the lenses that we look through when we're doing work out in the community and working with our partners and our providers. We're a really diverse group. We're bilingual culturally, a lot of lived experience within our department, similar to other divisions, professionals, educated, master's and doctoral level professionals, licensed folks, considered subject matter experts in a lot of areas in substance use disorders and treatment. A lot of folks that really know the regs inside and out, and we're really fortunate to have such a great staff and leadership team here in the substance use department. So as you can see here, our org chart, Lori oversees our division, and then Ed and myself are the HPMs or health program managers. And then depending on kind of what is going on, if it's administrative or contractual, things like that would be up in Ed. And then anything in program or systems or clinical matters would then go up to me. So our COVID response, want to make sure I highlighted that, especially for this board, and something that's very important right now as we kind of come out of the pandemic and the restrictions, but wanted just to highlight some of the things that we did during this time. We did implement COVID social distancing. We transitioned to a telecommuting, telehealth services, both for our staff and for our treatment services, which we found to be highly effective. I think a lot of folks would comment that one of the good things that came out of the pandemic was that we did see that telehealth can be a value. It can reach and provide access to folks otherwise that would not have sought out services before the pandemic. So we're really excited to hopefully keep some of that in place as we come out of the pandemic, and as we lift the restrictions. We're hoping to maintain that as a service delivery vehicle for our treatment services. We did have some COVID outbreaks in our residential treatment facilities, which did provide some challenges. Quarantine, halted admissions, so on and so forth. So again, we struggled at times, our providers struggled at times, but talking with our providers, they felt very supported through this from the county, and our consistent work with public health and the guidance that you guys were giving to us, we were able to give to our providers. So we think that we did a really good response in that sense to make sure our providers had what they needed. We did, again, move some of our substance use disorder assessments or our SET assessments from main jail and RCCC. They were halted during the outbreaks, but again, those have returned, and we're also utilizing virtual delivery methods for those as well. And we anticipate having that as an option moving forward as we continue to engage the correctional health community. And then, similar to other divisions, we consistently looked at the county COVID response, general resource and provider web pages, and our providers were given those on a regular basis. We also provided a support group, which we found to be very valuable. We had that from 11 to 12. And so folks and clients who were frustrated, who were at risk for relapsing because of COVID, because of the lockdown, and so on and so forth, they were able to get some specialized support through this support group. And again, as we phase that out, we are looking to incorporate kind of what worked in that support group into our ongoing service delivery. Cultural and language needs are very important to us. We do embrace the cultural and linguistic diversity of our community. We try to make sure that that's represented in the contracts that we have and the providers that we have and the staff that we maintain and seek out. So we're really very important to us to make sure that we have a diverse workforce. So we work with the department as a whole to make sure that we're recruiting in the right locations. We do have our threshold languages listed there. As you can see, we have a 7th threshold language now, Farsi. So that was recently added. So we do provide our services and our documentation and educational materials in those languages. And again, we provide interpreters as well as needed, including for ASL, our American Sign Language. One of the big highlights, if you're not familiar with this already, is the Drug Medi-Cal ODS, or Organized Delivery System Waiver. This came in place a couple of years ago, and this really was a game changer for us. It really allowed us to provide services and then have those reimbursed from Medi-Cal. It allowed us to really expand the services that we deliver and what we can offer to Sacramento residents and to our partners. And so it was, a big game changer for us. We were able to partner with some of our managed care partners listed there on the screen: Aetna, Anthem Blue Cross, HealthNet, Kaiser, and Molina are our big managed care providers and partners. We were able to really, like it highlights there on the screen, implement new services, case management, physician consultation, expanded medication-assisted treatment, residential treatment, withdrawal management. So many things became available to our residents. So this certainly, in my opinion, being in the profession for almost 15 years, I would say this is one of those things that when I retire one day and travel to Death Valley and vacation, that I would say that this is probably one of the big things that happened in my time as a professional. So very excited about that. Continuum of Care, just highlighted there. I'm going kind of clockwise from residential. We have our residential, our detox and our withdrawal management services, sober living environments, recovery residents, our perinatal services, which I'll talk more about in a little bit, our DUI programs, our specialty courts, drug diversion programs, prevention, which is big for us. We're very invested in prevention, and we do find value in that. Interesting fact, we recently went through an external quality review, and they were really impressed that the P in our SUPT, substance use prevention and treatment, the auditors were very impressed that we kept prevention in the name of our unit, because they said when they go around to other counties, they don't see that very often. Prevention is kind of something that's kind of, yeah, they do that over there, or that's somebody, that's a provider that does that. But it's something that our unit and Lori has really embraced and really made sure that stays present in what we do and our work that we do. So I'll talk a little bit more about that and some of our partners and our collaborations that we're doing to really make sure that prevention stays at the forefront of our work. And then medication-assisted treatment, MAT, otherwise you might hear it said around town, and then our outpatient services, and then our intensive outpatient IOT or IOP, but it's basically kind of a step up from just standard outpatient services. So number one approach that we use is the client. So the needs of the client and where they are in their recovery really drives their care. We use the ASAM, American Society of Addiction Medicine, their assessment, which is evidence-based and well-researched and well-grounded in research. We use that as a measure to where to place someone, because what we know from the research is undertreating or overtreating can have negative effects on a client. So we want to make sure that we pinpoint their exact needs, and we make sure that we provide the treatment and get them linked to the provider that can target those exact needs. So we're very client-centered and client-specific here in the substance use unit. Some of our assessment and referral access points may look familiar to folks in the meeting, but wanted just to highlight those again. Our systems of care, both for adult and youth, we do have those as a access point. Our collaborative courts, which I'll talk about in just a few slides. The Sacramento County Jail, RCCC, Guest House, CPS, our Sacramento County Health Center, Probation Department, YDF, for our youth detention facility for youth. Again, our system of care, and then self-referral. So these are kind of the main assessment and referral points that we typically receive referrals through. But every day we receive a referral from somewhere else that's maybe a kind of a one-off, and that's totally fine with us. We're always kind of expanding our assessments and our presence out there in the community. Interesting fact, I'll talk about possibly a little bit later if I have time, but we're working with the Homeless Collaborative and some of the work that the folks are doing on our mental health side, and getting ASAM or our assessments down at the level of the encampments, getting folks linked to services out there in the field. So again, we're trying to be really innovative in where we place our referral access points and where we're doing assessments to make sure we're getting folks at the highest needs into services. You oftentimes will hear this system of care. That's kind of our go-to when people are like, well, how do I get into services? System of care tends to be kind of a main point, but doesn't have to be the point, which I'll expand on in just a moment. It is the entry point for substance use prevention and treatment services. for like residential care, any of the higher levels of care, residential, withdrawal management, things like that, you can go into system of care, or we do that virtual now as well. And get those assessment done takes an hour or so, and then you can be linked up with a provider pretty quickly. 8 to 5, Monday through Friday, standard county hours. And we are planning to return to some level of in-person in June or July as everything gets worked out and we roll that out as a county. We're excited to return to in-person services. Like I mentioned, some clients are eager to get back to in-person, and other clients have found virtual services to be what works for them. And so we're going to hopefully offer both of those. We utilize this thing called federal priorities when we provide services, and we triage for services. Our highest priority, as you might imagine, and for right reasons, is our pregnant IV drug users. So folks that fall in that category are considered our highest priority. And so we basically kind of stop the world from turning and get that person into services as soon as possible. Followed then by folks that are pregnant, IV drug users, going counterclockwise, multi-system involved. So folks that might be involved in the criminal justice system or justice involved areas, and also in mental health or substance use or co-occurring. So folks that are in more than one system, and then all other clients and would fall in line. So that's kind of the priorities that we use when we receive clients and we have to triage. Luckily, we do have a lot of providers out there that are able to pivot quickly and get folks in that are considered high priorities. So just kind of going over on a high level, our outpatient and intensive outpatient services. These levels, if you're not familiar with the ASAM or the American Society for Addiction Medicine, they kind of set these levels. And so we follow that as evidence-based approaches. So our level 1 is kind of your typical outpatient, what you would expect with showing up, doing some treatment, going home for 9 hours a week for adults, about 6 hours for adolescents. We're fortunate to have about 10 sites across the county. Our sites are located in the southern part of the county, northern county, downtown. So we're very blessed to have a system that really spans out throughout the county. And then we also have some providers that are slightly outside of Sacramento County. So folks that are living on the border or live or are traveling for work outside of Sacramento, we want to be able to get them linked up with some providers that might be slightly outside of Sacramento counties and catchment. Level 2 is our intensive outpatient, slightly more services, about 9 hours, more treatment involved, more high intensity services. And we have 4 program sites around Sacramento County that do that level of care. For withdrawal management, sometimes called detox, we try to use withdrawal management because detox kind of has this connotation that it's just alcohol, but there's other reasons to withdraw and go through withdrawal management. So levels 1 and level 2, we have our outpatient withdrawal management. We have 7 sites across the county. As I mentioned, we have 2 outside of Sacramento. And then we have our narcotic treatment program structure, which basically is 21 days of detox or 180 days of detox. Again, the ASAM and the assessment is specifically tailored to the client's needs. So depending on what the client needs and what's clinically indicated for that client, that would then drive kind of where they fall within this particular withdrawal management continuum. And we also have a slightly higher level for this particular category, 3.2, which is withdrawal management in a residential setting. So we have 3 program sites there, and that basically is a person's living there, they're receiving treatment throughout the day into the evening. So a highly structured, really treatment-focused program. And we have, luckily, we have some perinatal women programs as well. So folks that are either pregnant or parenting, we're able to get them linked up. So if they need to bring their child, for example, while they're living in residential treatment, we do have providers that allow that. So it really helps to keep the family connected, keep kids with the mom. And we find that to be very successful and continuing to grow that program as we can. 3.1 is our residential, and then 3.5. So again, as we move on the continuum to least restrictive to most restrictive, 3.1 just again has slightly more services available. 3.5 is a 24-hour kind of structured living environment, lots of services, very saturated. So these are folks that are maybe at high acute risk for relapsing, or maybe have just gotten out of the hospital or something like that. We consider them to be pretty high risk for relapsing. Our narcotic opiate treatment programs. So we are excited. We continue to expand this, but we currently have 5 providers 7 providers in Sacramento. 5 of them are in county, and then again, 2 of them are out of county, slightly outside of our county lines. And we find out again, folks that are commuting or working or going to school or whatever find this to be helpful. We do provide and contract with providers that provide the continuum of medications for withdrawal management and opiate treatment. So we do require that in our providers, that they don't just offer methadone, that they offer other options in addition to that. And again, that's been well received by our providers and by our clients. Recovery residents, and so something, again, we're continuing to expand. This is kind of on the very end of our continuum. So as folks have kind of gone through withdrawal and they've gone through the treatment, this is a nice place, again, for folks to kind of, try out their wings, get on their feet a little bit, see how they're doing, use the treatment, use the services that they've been getting this whole time. And so we're excited to have 7 sites, about 139 beds in this particular area. But as you might imagine, this is a huge need for us, and we are continuously looking at funding opportunities and ways to expand this particular area in our continuum, because we do find that, folks that don't go into recovery residence or don't have that opportunity, they're just barely kind of holding it together, and they're just barely sober. And what we find is that this recovery residence or this kind of setting really kind of moves the needle enough in the sense of them being able to really live a sober and, really advance their recovery. We also have 71 beds for women and their children, as I mentioned in a previous slide, available for folks. Youth treatment, another area that I'm passionate about, and that the unit and the department remains passionate about. What we know, the research is overwhelming, and I know I'm talking to the choir here, preaching to the choir. And you all know this, but if we can get some interventions to our youth, the younger they are, we know that the outcomes are better of them converting to a user in their adult life. And so we do have 6 providers across Sacramento County. We're very, very excited to continue to grow this. One of my staff and I are just starting to engage yet another provider that's well known in the community, and hoping to facilitate contracting with them and expanding youth treatment in Sacramento. We also have Rio Vista Care servicing kind of our surrounding smaller counties kind of around us. So we're, again, a big proponent, and I have to thank Laurie Miller for this, of really kind of thinking big picture outside the box of, of having these available just slightly outside of our county line has really been tremendously valuable for keeping folks in treatment and keeping folks recovered. We provide services for 12 and up, and we also have providers that do services that are specific to our TAY youth, our 18 to 25 transitional age youth. And so again, we feel like that's a high risk age group. And so we really try to target that as well. Just because you're 18, the thought of like, well, you're on your own and good luck, really having that time to transition, having those services available to you as you turn 18 and as you get a little bit older, we find really is valuable in the long-term sobriety for folks. Our youth treatment services are available both in the community and in schools. As you might imagine, COVID has kind of put a wrinkle in that as schools were closed. And as schools are just starting to reopen, we're just re-engaging those conversations with schools about what that might look like of getting our folks and our providers back into the schools. But we've heard from our teachers and our school districts and our principals that we work with that this has been a tremendous miss for our clients. Our kids have stated they missed this. And, we just didn't get the big bang for our buck with doing it via Zoom, because the kids were on Zoom all day long. And that whole Zoom fatigue thing really set in. So transitioning to Zoom for our school-based services, we didn't see as good a results as we wanted to, but I think it just speaks to the eagerness to get back into our schools. And then we provide treatment for alcohol, marijuana, and other drugs of choice, the whole continuum, and big into prevention here as well. So you'll see us talk about here just a little bit of prevention programs that really target our youth. As I was just mentioning, we have some providers. I know the slide's a little bit full, so feel free to read that on your own. I'll just kind of give a high-level review in the best interest of time. But we partner with our Public Health Institute, the Center for Collaborative Planning. They do a lot of different workshops and trainings in our schools and in our community, a really top-notch provider for us. We also partner with the Sacramento County Office of Education, which partners with Friday Night Live and Club Live, and those are big programs in our high schools and our middle schools of trying to present alternatives to drinking and drugs to students. And so very successful, been around forever. When I joined the division recently, I was able to find out that I was in Friday Night Live years ago, and the lady who kind of runs this remembered me. So it's just a small world, a very passionate group of folks that run the Friday Night Live and Club Live program. And so they're very invested in making sure that kids have alternatives. We also partner with our Omni Youth programs, another spectacular provider in our portfolio. They provide a community education for drug-free youth, lots of trainings, lots of workshops. They're also known for, they have a particular model that they utilize, an evidence-based, well-researched model that they go out and they actually kind of certify organizations to provide this. And so again, a very innovative approach. So, how do you, kind of touch multiple people while you go out there and touch one person who then touches 3, who touches 10, and it's a really great approach. And then we have our Pro Youth and Families, another great organization, and they do a lot of training, a lot of in-school support, both on school campuses. They do a lot of media blitzes and Facebook, all the social media platforms that you would expect. They're engaged in those as well, and they're really keen on making sure that we're targeting our at-risk populations and hard-to-reach populations as well. So we're excited to be working with them. Our Options for Recovery program is our perinatal program. So as if you recall from our federal priorities, this is something that's very a high priority for us. There's no services. Services are on demand, no wait whatsoever. So folks come in, they do their assessment, and we immediately get them linked up. One thing I wanted just to highlight, speaking of that, when I was talking about system of care, we talked about that's a entry point for services, but that is actually not the only way you can get into services. With the exception of like residential or withdrawal management or higher levels, folks can actually go directly to providers. We operate an on-demand treatment continuum, essentially, where folks can go directly to one of our providers and say, hey, I need services, and they can start with that provider. And the provider just has to do some things on the back end to make sure that they confirm eligibility, things like that. Real simple process. So again, folks don't have to go through system of care. If it's just kind of outpatient or kind of standard routine treatment, you can actually go to any of our treatment providers or their satellite offices and get linked up. So again, a very innovative approach. Not a lot of counties do that. We do. Collaborative Court. This is one of our real successful programs. It's been highlighted across the state and across the nation. Kimberly Grimes is my program planner over that particular operation. She has been sought out by several counties, both northern and throughout California, to provide this and present this to other counties who are looking to embrace this because it's been such a success. And I'm very, very proud of having it in our service delivery line as well. And there's a variety of different things that fall under the collaborative court. So I can go into more detail if there are questions or give you more information down the road, but everything from our recovery court to drug diversion programs, family treatment courts, folks that are involved in a dependency system, Prop 36, mental health treatment court, reentry court, veterans court, all those things. All that, again, is a source of referrals for us. We have staff actually embedded. Our senior mental health counselors are actually embedded in a lot of these programs that are there to provide services kind of immediately, get them linked up, get them into services, so they don't have to worry about staying in either in custody or probation, waiting to hear back. We can usually get folks connected pretty quickly and into services. And our partners like probation are really, really happy to have this as an option for them. Our DUI programs, we offer a couple different programs, 3 different programs throughout Sacramento. They're, again, strategically located so that folks have access no matter where you live in the county. Those are listed there as some of our providers. We do provide our first offender program and then our multiple offender program. And again, this is kind of set forth by Department of Healthcare Services regulations and statutes around where, which one you have to enroll in and for how long. That's kind of set forth. So we don't necessarily decide if you go into a 3, 6, or 9 month, for example. That's set forth by the penal code and by Department of Healthcare statute. So we follow that, but it's been, again, very successful. We were able to shift this to a virtual platform during the pandemic, and we found it to be, again, successful. We did find, just as you would imagine with the shutdowns, there were less DUIs during that time. So we actually found a little dip in this program. But as things open up and as bars and restaurants open back up, we anticipate that the little dip that we had will quickly be back with folks getting arrested and getting referred to this program. So I mentioned our coalitions. We really are proud of our coalitions. Just a couple I wanted to highlight. We have our Sacramento County Coalition for Youth. It's a really, really innovative coalition where we bring youth, we bring law enforcement, we bring a lot of stakeholders from around Sacramento and around the state to this collaboration. We're working on issues, getting ideas, hey, how do you think we could do this? What do you think the issues are? Really hearing it from our youth and really having our youth teach us and present to us where we really need to be paying attention. It's a very valuable coalition. If you're interested in that, I can send you the dates and times of their meet. We'd love to see you there if you want to sit in and just kind of get an experience with that. We also have two very, very, very successful coalitions. One is the Opiate Coalition, and then we have the Methamphetamine Coalition. And these coalitions are made up of professionals, medical professionals, ED doctors, law enforcement, state officials, federal officials, things like that. And again, we're all working together for the common goal of how do we address this. And a lot of our strategic plan, a lot of our kind of marching orders, quote unquote, really come from this, where we're hearing where we can really get the biggest bang for our buck. And it's really nice to be seeing all these folks kind of working together for a common goal. It's one of the things that really, again, when I kind of hang my hat when I retire, I'll say, these coalitions, sometimes they don't really produce a lot. In our past, we've all known of coalitions that don't produce a lot. These are producing just spectacular results and spectacular information that's really informing what we're doing. Some of the other partnerships that we're proud to highlight for you today, UC Davis Medical Center, we have partnered with them. They recently went through and got Medi-Cal certification. So they're going to be able to provide some services right in the ED, right? Getting folks on medicated assisted therapy and treatment then and there. And so we don't have to worry about referring folks and having that delay. We also partner with them and working with them between the connection of methamphetamine and heart disease. Recently was talking to one of the chiefs over there in the cardiology department. My wife's also in this particular area for one of our hospitals in the area. And it is really staggering to see the amount of heart disease or heart damage, heart failure that results as a result of meth use. And so we're really kind of working with them and through our coalitions of what we can do to try to get their patients the access to either be recovery services or prevention services. Also working with them around mental health, HIV. We also know there's a link between sexually transmitted infections and drug use. So again, we're working with them as much as we can to get them the information and services for their patients. We work with Primary Health, Sacramento County Health Center down on Broadway, our public health partnerships, as I mentioned, trying to work with, highlight the relationships between meth and syphilis, for example, and the perinatal impacts of drug use. And so we're partnering as much as we can. Lori and Ed and myself, we're constantly just like we're doing today, trying to really get in front of coalitions and advisory boards and as much as we can to really get our services out there. We have lots to provide, we have lots to give, and sometimes it's just a matter of letting folks know that we exist. So we're out there. Have presentation, we'll travel is kind of my motto. So we also partner with CPS. As you might imagine, there's a lot of drug use within folks that are referred to CPS, unfortunately. And so we work very diligently. I'm on a work group with some folks up in CPS leadership as we speak, of trying to figure out how to get folks referred into treatment sooner that get involved in the CPS system. Our criminal justice partnerships are, again, spectacular. It's an area that I come from as a forensic psychologist. I was chief psychologist for the Department of Corrections and for the state of California for many years. And I do remember working at the state that Sacramento County had a really great reputation for what we did with our criminal justice and justice involved individuals. So I'm very, very proud to be working with some of our partners around this, of really making mental health and assessments available through our collaborative courts in the jail settings, our CCC, and our youth detention facility over there off of Kiefer. We are just trying to get in there as much as we can, because we know that oftentimes this is a risk factor for going back into custody or being rearrested, is drug use. So we want to try to get folks into treatment as soon as possible to avoid that. We also are very much involved with our hospitals like Kaiser, for example, and Sutter. We have navigators in there that we work with. And again, trying to get the folks that are assessing folks in the ED aware of what we do and what we can provide. So hopefully that they can get those folks linked up to our system and hopefully have that client or patient not going back into the ED and putting a strain on the hospital system, but instead getting services through us. So I know I did a very high level, very quick presentation, but my information's there. Again, if you'd like to know more information, I could set up a call or meeting with myself or with Lori. We'd love to share more. But again, today's purposes was just kind of giving you the opportunity to kind of see a little bit of a lot. But if you want to see a lot about a little bit, let me know, and we can certainly make that happen. So I will stop sharing and hand the ball back over to you, and then open up dialogue for questions. Comments, ideas?
This is
That was a great
Farla.
presentation.
Can you hear me?
Yes.
Oh, great. Thank you. That was amazing. That's a huge amount to take in. There's just so many programs. I'm really amazed. It will take me a while to absorb it all. So I have a few questions, some more general and some more specific. But I wanted to make sure I asked what you felt right now was the biggest challenge you face.
In regards to getting folks into treatment or
Overall needs, yeah. Do you have you seem to have so many programs. So are they all staffed so that are there waiting lists, or people able to get in when they want to, when they can? Do you see a big need that you're having trouble meeting, or?
Yeah, for the most part, about 80% of our continuum of care there is treatment on demand, and folks can get in today. We do have some kind of, again, higher level services such as our residential and our withdrawal management that, we have some needs for expansion in that area, and we are continuing to seek out providers. I just had a meeting with one of the large psychiatric hospitals here in town that wants to bring some of their beds online for detox and for withdrawal management. So it certainly continues to be a need for us in an area that I know Lori and myself and Ed, we are working diligently to expand in our system, just because those are high level, kind of high touch services, and not a lot of providers either have the availability, staffing, or the facility to do that. So yeah, our residential and our withdrawal management, we do have a slight wait for those services. But if you're a high priority, so like a IV drug using pregnant woman, then obviously you would go to the top of the list in that. So we wouldn't, our federal priority folks are not waiting very long, if at all, to get into those services.
Okay, wonderful. By the way, I love the presentation. I really appreciate the overview and how you presented it. One other thing comes to mind. We've heard a lot about correctional health and people able to maybe be diverted through some of the court programs so that they're not in the jails and maybe in these amazing programs that are available. Do you see, and obviously that's not in your control. So I'm presuming that anybody who is deemed able to be diverted into some of these other programs can get services. My question is, and it's sort of outside your purview, but are the judges utilizing this as much as they can in their judgment of who's kind of fit for that approach, and programs instead of being, to be diverted instead of being incarcerated.
Absolutely. We have a standing meeting with our presiding judges and the bench. And so we're constantly presenting our services. We just had one just a week or two ago. And so that we maintain consistent contact with them, letting them know, again, what we have to offer. They're always asking for more and more, just because I think as the courts open up and as cases start to get heard, that there's kind of a need. So I think there's kind of a pending tsunami coming through the courts in some ways that the judges are a little bit worried about. And so we have folks embedded in those systems that judges can refer someone to through probation. We have folks that go to the main jail, RCCC, that again, if there's an opportunity, if the judges, again, think that it's a safe disposition for the case to be referred to us, we certainly are there, ready and willing. And we're constantly, just like I'm doing today to you all, we are constantly doing presentations to the judges, to those kind of officials, so that they're aware of us. And again, what we say is, when in doubt, refer, and we can always educate you on why we can't necessarily help, but most of the time we can help, and most of the time we can actually take that client off your hands. I don't know, Lori, if you wanted to, I know you've been working with the judges for many, many years, if you wanted to add anything to that particular question.
Not necessarily, I just wanted to share that there are some great programs and some expansion efforts that have happened in the jail. And I know Sandy's on the call, and so we just appreciate our partnerships with primary health and correctional health. So people are getting more services while they're in custody. And then certainly those who are already working or involved with the Superior Court may have a DA or public defender, probation officer on their case. And those folks are the ones referring into our collaborative courts.
Thank you very much. I appreciate it. I'll let others ask questions for now.
Andrew, I'd like to ask you a couple questions about how you prioritize methamphetamine users. I see in these federal priorities, there's an emphasis on injection drug use, but maybe it's not apparent to me how methamphetamine addiction fits in amongst those priorities.
Let me see, Lori, I'm not sure. Do you want to answer that?
I would just say that certainly meth is the #1 substance abused here in Sacramento County. So I see your point, but there are lots of times where people are polysubstance users. And so that's kind of where we're prioritizing that. I mean, the federal priorities are not set by the County of Sacramento, they're set by the federal government.
Right.
And we would certainly prioritize meth users if we were able to the top of the list. But a lot of times they are actually getting into treatment as a priority, again, because of the polysubstance use or the high risk factors that are involved in those particular cases. If they're involved with the criminal justice system or their child welfare system, a lot of times those folks are kind of elevated.
Yeah, I guess the reason I'm asking is because I work at UC Davis Medical Center, and we see a lot of heart failure patients who repeatedly bounce back between the community and the hospital when they have an exacerbation of their heart failure. But on top of that, they're dealing with methamphetamine addiction and unstable housing. And it's a constellation of lots of social complexity. And it feels like we don't have anywhere to direct their care in the community once they're discharged. And I was thrilled to hear that you're working with probably Dr. Kaderis, because he's working with me to figure this out. And I think the Methamphetamine Coalition is wonderful, but I'm just wondering what resources are available at discharge for patients who fit this profile so that they get the services they need.
So a lot of times those patients would fall into that high federal priority list because they would be the multi-system users. So although they may not be injection drug users or pregnant, they would still fall into that because, again, they're seeking services through the hospital setting. They may or may not be following their medical orders around use. They may be involved and need Department of Human Assistance, support, criminal justice involvement, child welfare involvement. So again, a lot of those folks, like I said earlier, do fall into that high risk category and priority categorization.
Okay, great. And then my last question for you is, what's kind of the philosophy of these programs? Is it that the individual has to agree to abstain from use, or do you use more of a harm reduction approach where you kind of meet the patient or the person where they're at And if they relapse, they're not kind of kicked out of resources that are important to them.
Yeah, we utilize harm reduction. We don't have an abstinence approach. Harm reduction, our providers recognize that relapse does happen, and it's part of the natural course of getting sober and getting into recovery. So we do encourage our providers to utilize that philosophy when approaching treatment. Most of our providers, I think all of our providers actually have that actually involved in their curriculum. They use evidence-based curriculums. And so that obviously we would not be okay with the provider kicking somebody out just because they used. Oftentimes there's other opportunities for that provider. Either maybe the person needs higher level of care, maybe they're not quite in the level of care that they need. So there would be some movement within the continuum to get that person. But no, kicking somebody out to the streets or kicking someone out of treatment because they relapse is something that we simply would not embrace from a philosophical standpoint. And also harm reduction, we know, has a tremendous value. Long-term is what we know is sometimes folks aren't ready.
Yeah.
And so, kicking them out only sends a message that the system doesn't care about them. And so again, it's a approach that we don't tolerate with our providers, and our providers luckily really embrace that with us as well.
Great. Thank you so much.
Steve.
Andrew, hi. I really appreciated your comments about the importance of prevention. And what I'm wondering about is if you've been able to measure the impact of the legalization of marijuana a few years ago, and how your unit is also approaching the issue of vaping.
Lori, I don't know if you want to speak on that. I know there's a lot going on before I joined the unit in regards to our tobacco education.
Yeah, with the legalization of marijuana, a lot of our prevention programs were focused on the reduction of underage marijuana use in addition to alcohol use. And so a lot of our data comes from the school systems through the checks data. And we did see some improvements through our prevention programming, as well as our Sacramento County Coalition of Youth efforts in regards to this area. I want to say it was like a 10 or 15% reduction. Our prevention strategic plan was just updated. I don't have the data off the top of my head, but there was significant improvement just through the prevention efforts that we implemented here in Sacramento County. And vaping is actually part of all the work that we do, since the original prevention strategic plan was focused on the reduction of underage drinking, and through obviously the last couple of years we were seeing young people drifting or gravitating more toward marijuana and cannabis. And so a lot of our prevention programs, again, is transitioned into adapting and focusing on that work. So vaping is a big part of what they do in terms of education and prevention. And a lot of social media platforms, they're addressing that through those means as well.
Larissa?
Maybe a very specific question. I work in the UC Davis ED as a physician, so mainly working on our hepatitis and HIV screening program, and obviously partnerships with our ED Bridge program as well. But I have a question about, it's maybe very specific, but we have some patients from Kaiser, like who have Kaiser insurance, that come to us, and are there resources for these patients that do have this, exchange insurance with Kaiser? It sounds like Kaiser doesn't actually cover medication-assisted treatment. And so sometimes we try to get them, get them started on the Suboxone, but then, the copays are so outrageous that, they can't really afford it. So a lot of these patients seem to be getting Suboxone on the street. So I'm just trying to, I'm wondering if there are county resources to help these patients, even though they do have quote unquote insurance.
There are resources for that. So we partner with all of the hospital settings, and Kaiser is the only one who actually has a chemical dependency program. But like you said, they don't do a lot of medication assisted treatment. So their medical needs are met through the managed care plans, and their behavioral health needs are met through the county systems of care on both on the mental health side and the substance use side. So those folks, if they have, say, Kaiser Medi-Cal, they would be referred to Sacramento County, and through our narcotic treatment programs for methadone and the other forms of medication that they're able to provide there.
So I think the key there is Kaiser Medi-Cal versus Kaiser Commercial.
Yeah, I think that's the problem I'm seeing also. Like some patients, there are some patients on Kaiser Medi-Cal, but there are more patients that I'm seeing Kaiser Commercial that but that, you know, maybe they don't qualify for Medi-Cal, but they don't have the resources to pay for, and one of them told me the copay was like $400 or something for a.
I know I have some friends that work in that particular system. I know Kaiser is continuously looking at improvements in their system, and I know that is an ongoing discussion that they're having. And so I have hope, fingers crossed, that hopefully may be addressed on the commercial side of the house very soon.
Okay, thank you.
Any other questions that Lori or myself can answer? Well, again, you have my information. Please feel free to reach out to either myself or Lori if you have any particular questions. We will continue to attend this meeting. We find it to be extremely valuable. So if you don't mind us kind of voyeuring from the sidelines on your meetings, one of us or both of us will certainly be here on a regular basis. So feel free if you have questions as they come up at our meetings, or again, feel free to send me an email or give me a call, and I'll get you connected to the right people if I don't know the answer.
Steve, did you have an additional question?
I always have questions, but well, I just one point. I'm not sure that everybody who's listening understands that much of the services that you've been discussing are provided by contractors, and I'm just wondering what kind of quality control program you have for contractors and how you measure successes. And as people are going, I'm talking about patients now moving along the continuum of care. How do you identify weak links in the programming that's available, and whether this is due to treatments that are actually available or to manpower needs that you have?
Excellent question. I will tell you, of all the systems I've been involved with throughout my career, I think that the checks and balances and quality control measures that we have in place in Sacramento County are among, I think, some of the best that I have seen. We do semi-annual and annual reviews. So my staff are going out, actually doing site reviews. They're looking at the charts. They're looking at the quality of the progress notes, quality of the client plan, the treatment plan that again drives treatment. We're looking at things like that. We're giving corrective action plans as needed and as required. We have a very, very strong relationship with our quality management department. And so we work with them. We have a weekly call with them. So we're always looking at ways to improve the quality of the work that's coming out of our contractors. So a lot of oversight. We also are looking at client satisfaction. You know, when we do our reviews, we're asking our clients, we're looking for opportunities for improvements. Like you were saying, you know, where there's smoke is there fire. We're looking at that. If we're working with our mental health colleagues. If there's complaints coming in on the mental health side for a provider that also provides in our system, we're looking into that. We're looking into co-leading investigations or co-leading exploration into that provider. So we share information freely. So in my opinion, you know, we are quick to respond, but also we have a lot of opportunities to find issues with our providers. And Lori, I don't know if there's anything you wanted to add on that one as well.
No, good job.
And we also, I mean, you know, the providers know that the state audits us and we audit the providers, and providers know that if they're not providing quality services, that there is a recoupment possibility. And so I think that, again, that really helps our providers to make sure that they're providing quality services that are evidence-based and are, you know, within acceptable standards. So they don't want to, you know, have to pay back lots of money. So I think, again, that's another tool that we have. We don't regularly like to use that. But again, our providers know that if they're not doing good work, that they run the risk of having to pay back money. Other questions that I can answer? All right. Well, thank you again for the opportunity to present. I'm just going to go on mute and I'll be here for the rest of your meeting.
Super. Thank you, Andrew and Lori. It was wonderful having you. That was a super presentation. So we are almost exactly on time with our agenda. So now we are going to open things up to Libby Abbott, who is going to share with us a PHAB working committee update. So Libby, take it away.
Great. Thanks, Tina. And thanks to the group. Switching gears a little bit and going back to something we've talked about in a couple of meetings in the past few months. I'll give a little bit of background so that everybody on the line sort of catches up to speed with where we're at, and then just kind of let you know where we are and how we're thinking of moving forward. So back in March, we had a PHAB meeting that was focused on addressing the COVID situation in jails. We invited decarcerate members of the community to present on their experience and their perspectives. And they described conditions that raised some alarms. A letter was drafted by PHAB and circulated within the group. Dr. Damiano provided responses that were really helpful, but sort of painted a different picture than I think what we had heard from the community and from members of Decarcerate. She also indicated that some of the response measures that we had originally proposed in our draft letter were already in place, and that there were also already some oversight mechanisms in place. So I think the realization coming out of some of that back and forth was that we have a lot to learn. We don't yet know enough to really be able to make a pointed or constructive recommendation. So fast forward a little bit, in May, we decided that we would probably need to form a separate working committee just to have a little bit more flexibility and a little bit more time to go deep on this issue. We've talked about this working committee being sort of an interim provision, and we have an interim scope. And the goal of that sort of this interim working committee is really just to, one, get more educated on the consent decree and its existing monitoring mechanisms for sort of health services in the correctional health setting. And then two, once we get ourselves more educated, to identify whether there is a gap in monitoring the state of health conditions and health services, and whether we have sort of a corresponding clear recommendation to make to the board. So we're still just sort of figuring out what we don't know. That's really the focus for now. And then using that to figure out if there's a gap that PHAB should be kind of probing and potentially making a recommendation around. And I do want to say, I don't know if Dr. Damiano, it looks like she's still on the line. Definitely hear the pushback that there's already monitoring mechanisms in place, and our goal is not to create burdensome oversight mechanisms or to sort of add to workload, but rather just to make sure we're responding to all of the concerns that were raised by the community and by Decarcerate, and to make sure that we as a board feel comfortable with the level of oversight that's in place, and its ability to ensure the basic right of health to those who are held in the county jail. So Farla has done some research on sort of what we can do through a working committee structure. We do have more flexibility in that structure. It can be up to 9 members, at least 5 would have to be PHAB, but we'd like to extend the offer to the community as well. And right now it's just Phil Summers and I don't know if he's had a chance to join yet, who are involved. So wanted to pose a couple of questions to the group, and I'm happy to field responses now, or I can put my email address in the chat and folks can send ideas afterwards. But a couple of things we wanted to put out there. One, is anybody on PHAB interested in joining this working committee? 2, do you have any recommendations for community members or organizations that we should reach out to as we're thinking about community membership on this working committee? And then 3, even beyond membership, are there other folks we should speak to? Our immediate next steps, as I said at this point, are just to get educated. So we're actually setting up kind of a series of stakeholder interviews just to understand what's the situation, what's the architecture right now with the consent decree and the oversight mechanism. So we already have a call set up with Rick Hare, the county council, and a few other advocates, but would love to hear your suggestions for any of the above. So if you'd like to join, if you'd like to suggest people who should join, or if you'd like to tell us who we should talk to, all of that input is welcome now or by email. It doesn't look like Phil's on the line, but if he is, feel free to speak up, or Farla, if there's anything you want to add, please feel free.
No, I think you covered it pretty well. It's the really early stages of this effort. So participation is welcome, and suggestions.
And I'll just put my email now in the chat if folks want to think on it.
Libby, what are some of the things you might want volunteers to assist with at this very nascent stage in the development of this work group?
I think we just want other brains on the issue. So helping us untangle the consent decree, which is sort of a big thing, and sort of map and understand the monitoring mechanism. So it's really, I think at this point, about thought partnership, joining calls, helping us sort of sort out the information, and then try to get to the bottom of this question of, is there a gap to be filled or not? And as a group, we'll work on figuring out what we then recommend to PHAB in terms of a way forward. Excellent. Well, thank you guys. If there's no comments now, feel free to reach out by email. And we can always update in the August meeting.
Super. Thank you so much for that update. That was great. All right, so we were going to have a potential vote on an executive committee member nomination. It's actually Larissa May. We spoke earlier today and she is willing to take on the assignment. However, I think I've lost my quorum. So Farla or Steve, I'm not sure how to proceed or if we need to table this until next month.
That's a good question. My understanding from the previous meeting is that once a quorum is established, then it doesn't matter if people drop off. You can still hold a vote, unless somebody wants to correct me on that. So theoretically, we could hold the vote and it would be valid, or we could wait for the next meeting and hold the vote then. But that meeting won't happen until August because our July meeting we don't usually hold. So it probably would be better to have a vote at this meeting.
I agree. So may I have a motion to approve, vote on the nomination of Larissa May to the PHAB Executive Committee?
Sure. Is motion to vote or motion to approve, whichever?
Oh, I think we would vote, right? Motion to vote.
Well,
so.
we have to bring up the motion, and I believe, and then have it second, actually, and then we vote.
Okay.
So
motion.
So
I think, let me just add in, Tina, that you may want to establish that there are no other people who are nominated first. At the moment, you've accepted one nomination, but have not opened the floor to others. So you probably should make sure.
Okay.
Simple question. If people are self-nominating, so the question is there anybody else on the board who wants to nominate themselves to serve on the executive committee?
We have lost, well, we lost Steve Heath. He had to leave the meeting to join another call at 1. I do know that we've spoken to Annie Tat about being an executive committee member, and she declined. So, but maybe to be fair, we should open this up to others who might be interested in volunteering.
Tina, would it be appropriate for anybody from my unit to volunteer at this point? Or are you looking for more community member based representation?
No, I think that this position needs to be filled by a PHAB member. So that's why we have a limited pool of folks to choose from.
You should probably go ahead and vote.
Okay.
Yeah.
All right.
You don't hear anything. But Lori, the members, community members or anybody else can also sit on the working committee that Libby was mentioning. So this is restricted to PHAB members, the executive committee membership. So I'm not sure if Libby proposed that this motion to vote.
Yes.
If she did, am I interpreting
Yes,
that
yeah.
correctly?
Perfect.
So I will second it.
Okay, so all in favor of voting for Larissa May to be an executive committee member of PHAB, please say aye or type it in the chat.
This is Farla. I say aye.
All right, so oh, great. So we have 6 ayes, so I believe it's approved. So welcome to the PHAB Executive Committee, Dr. May. It's wonderful to have you.
Thank you.
Okay, so now we're moving to the last item on the agenda, and that's public comment.
Yes, I'm a public public person. Just thank you to Larissa for agreeing to serve. That's important
Yes.
to help give guidance to PHAB.
All right, so it feels like there's no desire to have much public comment today. So I'm prepared to adjourn the meeting a little early this time if no one objects. All right. Well, thanks again to Andrew Mendonça for his great presentation. We look forward to seeing you and Lori at future PHAB meetings. And as Farla said, there will be no July meeting. So we'll look forward to seeing all of you the first Wednesday in August.
Have a great day, everybody. Thank you.
Nice seeing
care.
Thank
everybody.
you.
Bye.
Bye-bye.
Thank you so much.
Bye-bye.
Bye.
Thank
Bye.
you.